Hello to all Dental XP community. Welcome back. I'm Christian Coachman, dentist and ceramist here at Goldstein Garber Salama, and we will be talking a little bit more about prosthetic gingival reconstruction and restorations. We're going to start with this, actually show the case of this young beautiful lady, Kathleen, that came to our office. That was her initial situation. You see she came in with braces, and she had a car accident, big trauma, and she lost her front 4 teeth, and as you see, a lot of bone and tissue. So she, with her doctors, they went through a couple of procedures to try to reestablish her aesthetics. So she had a hip bone graft and a soft tissue graft, and we see after that we still were in a not very good situation. That's when she came into our office trying to see what kind of surgeries and what kind of surgical procedures, as another bone graft probably and more soft tissue graft, placing implants to reestablish her soft tissue design and try to give her nice 4-unit implant bridge here. When she came in, Dr. Maurice Salama was analyzing her, and he called me into the room, and we at that moment instantly saw the opportunity to give her a prosthetic gingiva restoration. That means a 4-unit bridge over implants with artificial gingiva, and that will probably save us, allow us to go ahead with the treatment without any further surgery or bone graft surgery. So that's what we did. She had enough bone already for placing the implants, and that's all we needed. So we went ahead and we planned from inception for artificial gingiva, and that's what I'm gonna be showing here, how we do that planning for these kind of restorations. The first thing was to develop a wax-up that could guide us and help us with the treatment plan. That's key for these kind of cases. So we can see here the wax-up with the pink wax and the white wax, reestablishing white and pink aesthetics, giving her the ideal situation back. So we did that with the information that we had and the information that she brought. It's very important for the technician to do a morphological research at this point. So we see here she brought an old picture with a big smile before the accident, and that when we see a patient like that with that beautiful smile before the trauma, that's actually our goal, to go back and give her back as close as possible the same situation. Also here, the picture of intraoral picture to give me a possibility to research the morphology of the remaining teeth, and that's going to be also very helpful for me to build the 4 anteriors. So analyzing her face and the aesthetic guidelines, analyzing intraoral morphology of the remaining teeth, and analyzing her old photos with the smile she had and the smile that she wants back. So moving forward with this picture of her face in mind, I went ahead and I did the wax up, trying to rebuild the soft tissue that it was missing with wax, and trying to give the same shape of, the same design of soft tissue that she had before the accident. And I used this kit from Smileline with those wax veneers, and on cases like this, and I set them up on the model as they were denture teeth, and that saves me time and gives me a nice and quick wax up. I think what is important in a case like this, because we lost so many aesthetic reference, we lost the 4 anteriors, and we lost also soft tissue. When we don't have the support of the soft tissue, the technician can lose the reference and can be fooled and can distort the morphology of the teeth during the wax up. So I really want something that I can try in the mouth to help me reestablish the right aesthetic. So I did a wax up with this little acrylic device that we can actually try in the mouth. We can see here in the picture, trying the wax up in the mouth, and more important, analyzing this wax-up in relation with the patient's face. So utilizing all the guidelines that we have: midline, facial midline, intraoral midline, smile line, lip line, the line of the eyes, everything together to give me the right position, 3D position of the front 4 teeth. And at this point, we're going to analyze these 5 topics here: midline, overbite and overjet, labial support, papilla position, and tooth morphology. That's what I'm trying to see here, and of course taking pictures always of each step to give me the information I need on my bench when I'm working in the lab. So now we see here the whole sequence: the pre-op, the wax-up, and in the mouth the wax-up, giving me this very precise information of where we want to be with the final restoration. And now the wax-up is going to give me the information to proceed with the treatment. So radiographic stent, surgical stent, and silicone indexes to fabricate my, my temporary. So we see here then the whole sequence. We have the wax-up in the mouth, the radiographic stent, going to the CT scanner and giving me a 3D image and a radiographic image of the relation between the ideal position of the crown and the ridge, the remaining ridge. And then also giving me the final surgical stent to place the implants exactly where I need them to be. So we see here all the image that the CT scanner can give. It's really an amazing tool. We can see in 3D the aspects, the size of the loss, how much tissue we lost, and what kind of procedures that we have to do to place the implants on the ideal position for a prosthetic gingival restoration. So the position of the implants is going to change if we were doing a conventional implant bridge, and the positions for soft tissue for artificial gingiva are a little bit different. So that's what we want to analyze with these images and establish the precise position of the implants. For that, we created this concept of the aesthetic quadrants that will give us some guidelines to establish the position of the implants. As we see here, we created some lines, and we call them the main guidelines, and giving us 4 different quadrants. We see A is the lip quadrant, B is the tissue quadrant, D is the restorative quadrant, and C the quadrant, the view quadrant. It's what we can see aesthetically, the aesthetic view. So with these lines, we have a whole procedure that we do, and we establish first, we can see here the profile of the gingiva, of the artificial gingiva that I want for my restoration, giving us this yellow dot here on the soft tissue, and that will help us establish another point in the bone that is going to give us what we call the bone point. In addition to that, we already know that every time we're doing a restoration with artificial gingiva, we always want a screw retain restoration. So that is give us, in comparison with the ideal position of the crown, we know exactly the axis of the implant that we want. So combining these 2 lines, we will have exactly the position, the 3D position of the implant that we want, giving us the ability to develop a nice profile of the artificial gingiva. So now we see here, by establishing, by analyzing the radiographic stent, we can now virtually design the position of the crowns on the computer and establish the position of the implants also utilizing the 3D software. And this will give us automatically a surgical stent to proceed with the surgery. And we see here always teamwork, that everybody is talking about teamwork. In these cases, it's very important to have this in mind here. Combination of the work with the restorative team and the lab team, and also the surgical team. So connect these 3 teams together to give the best for the patient. So always doing and planning these cases in combination. And here we see the basic principles, the basic guidelines for artificial gingiva restoration. We have these guidelines that we always follow. So in terms of grafts, what we want is always horizontal gain. So if we analyze this picture, what we want is to bring this ridge forward but not down. So every time, the bigger the vertical loss, the easier for me as a technician, as a ceramist, to restore and to give a nice pink restoration. And the other aspect is that the higher we go with the interface between artificial and natural gingiva, we can hide this interface behind the upper lip. So that's also very nice when we can do that. So in terms of grafting, we want horizontal graft if necessary and vertical reshaping. Sometimes we have even to move the ridge up a little bit, or always reshape the ridge, making it flat, so we have a nice interface and healthy and hygienic interface between artificial and natural gingiva. So that's what Maurice Salama gave me. He placed the implants in a position that was ideal for me, and we didn't need, in this case, to add more grafts vertically and horizontally. So he reshaped the ridge and brought that ridge up and making a flat ridge for me without any papillas in between the implants, to make it possible for me to design the bridge correctly. In terms of implants, we want less implants as possible, always following, of course, the mechanical principles. We want less implants as possible because that makes it easier to clean, easier to design, and easier and better aesthetics, because we have more pontics and less abutments, and that's always easier to work with in terms of aesthetics. Distal position of the implants, that means that on the gap that we are restoring, we always want to position those implants more towards the distal, leaving the more mesial part of the restoration for the pontics or cantilevers. It's, like I mentioned, it's always easier to work in terms of aesthetics, to work with pontics and cantilevers than to work with abutments. So we try to position the implants towards the distal, leave the abutments more towards the distal, and leave the pontics and cantilevers towards the mesial, the more aesthetic demanding area. More apical, of course, we want to go deeper with the implant to give me the right ideal profile of gingiva. If we go usually on conventional implant restorations 3 millimeters above the cervical of the teeth to place the head of the fixture, if we're doing artificial gingiva, we want to go 3 millimeters above the end, the apical end of the artificial gingiva, to give me this possibility to design the emergent profile and not create any kind of overlap over the patient's ridge, over the patient's soft tissue. And as I mentioned, the very important aspect also, lingual screw access, so we have the ability to design the bridge in a way that we can always screw the bridge in and out, make it retrievable for many aspects, and always check the design and the condition of the tissue underneath the artificial gingiva when needed. So we move forward here, Dr. Maurice Salama doing the surgery, and we have those two surgical stents always for artificial gingiva. So we have the regular conventional surgical stent that was made, that came from the image that we had on the software, and that will give us the axial position of the implant. So in this case, we're placing 3 implants, and this stent here on the left will give us the idea of the exact position of the implants. And then we always use a second stent that we call dentogingival or bone reduction stent, that we use to establish the depth of the implant. So the first stent will give us the position of the implants, the second stent will give us the depth of these implants, and if we need to reshape or reduce the ridge, the bone, sometimes, as this case, we did a little bit of reshaping to give me the ideal depth of the implants and to give me a flat ridge. So here we move ahead now with the prosthetic phase, doing impression as we always do, nothing new here. The working model, and we see here the whole process, the wax up, the silicone index, the temporary, and then the temporary with pink. And that's very important for us to look that the temporary was first made in the lab with acrylic, and we always try to do a very, very aesthetic temporary on cases like this to really try the design and the solution of the artificial gingiva. So we do the temporary in the lab over the working model with white acrylic, and then we move to the mouth, we screw this restoration in, and I do the pink part with pink composite directly in the mouth. And that's the final result. Because of that, because we are doing intraorally this procedure, we can achieve really, really nice result. It's much easier to do it in the mouth because we can match the texture, the morphology, and really blend in the interface between artificial and natural gingiva. So we have here the final result of the temporary, and we see that the interface is here on the sides here, that the patient has a high lip line showing this interface, so we really have to work very well on these two areas to hide the interface, so in a way that the patient in a social distance cannot notice that there is some artificial material replacing her missing tissue. And that gives us a perspective, a different perspective about artificial gingiva, because the result with composite in the mouth was so good that me as a ceramist, I was in trouble to try to reproduce that now on the final restoration with ceramics. So that, as we see here, the provisional in the mouth, really the interface of this area, the most important aesthetic area on this restoration specifically, the way we could blend in with composite in the mouth. So that has actually made me change the way I do pink restorations. Instead of doing only pink ceramics, I tried to follow the same principle of the temporary on the final restoration and finish this restoration in the mouth with pink composite. So let's see how we did this. First, a metal framework, conventional metal framework. I did the ceramics, and I actually finished the ceramics without the pink, and we tried it in the mouth. We checked all the aesthetic principles, the shade, the balance between the crowns and the lower crown, the lower natural crowns, and the relation with the lips, still without the pink. And when everybody was happy about the ceramic crowns, we finished the crowns, we glazed the crowns. And after that, we then proceed with the artificial gingiva, with composite. So now we have to prepare the cervical area of this bridge, the roots of the crowns, to bond the composite. So what we do some mechanical retention, then we protect, as we see here, we protect the crowns with wax, so we save those areas that we're not going to bond the composite, and we proceed with sandblasting, acid etching, silonating, bonding agent, and I actually do the first layer of composite out of the mouth in the lab with flowable pink composite to guarantee a nice bonding between ceramics and composite without interference of saliva in the mouth. So after we have that, then we are ready to go back to the mouth, screw this bridge in, and with composite, with pink composite, and here I'm using a kit from Gradia, GC, they call the gum kit from Gradia, and also Bisco has some nice pink composite shades, and other companies they also have. And now with the final restoration in place and screwed in, I proceed with direct composite bonding. And as we see here, the bridge in the mouth first placed, the first layer of composite being made intraorally, and then light curing every step, and then proceeding, adding more pink composite in the mouth until we reach the papillas, and then I ask the patient to try to give me a smile and compare the position of the papillas that I placed in comparison with the upper lip and in comparison with the other remaining papillas. And now the pink composite, intraoral pink composite, it's done, it's finished. So it's time now to remove the restoration. So unscrew the restoration. We see we have some ledges here, the edge that we need to trim. So I go back to the lab and I'm going to finish this in the lab. I'm going to do first the final light curing cycle in the lab with the machine, and then I will trim these excesses and I will fill in some gaps or porosity or anything, and then I will proceed with the polishing and glazing of the pink composite. So we see here the sequence of what I actually do in the lab. If we imagine that this is the bridge in the mouth in comparison with the patient's ridge, and here I'm adding the pink composite. So now when I remove the the restoration from the mouth, we have this concavity here and a ledge as we see here, and that's not really hygienic, that's not good, so we have to get rid of that. And the way I do is first I reshape a little bit the buccal of the pink, bringing this back, inclining this back a little bit, not too much, to not create a too steep inclination. And then I fill in from the bottom of the pontics with composite, as we see here, to create a flat interface here, a flat interface underneath the restoration, and that's going to give me a very hygienic restoration, hygienic pontic, and a nice interface with the natural gingiva, and most important, an aesthetic interface here where the artificial gingiva ends and the natural gingiva begins. And also create a little compression, little pressure on the natural gingiva that also is going to help me to redesign the natural gingiva to fit better my restoration. So as we see here, the restoration already, the pink finished and polished and glazed. We can see underneath we have cleansable surface underneath, very well polished and glazed. And here comparing the provisional with the final. So we see here on the bottom the provisional, so it's acrylic teeth, pink composite, and the final restoration with ceramic teeth and also pink composite, giving me the possibility to reproduce the provisional in a very predictable way. And that made my life much easier and made us very comfortable to offer this kind of treatment to the patient, because from the beginning we can guarantee a very high level of aesthetics in comparison with the restoration that we were doing in pink ceramics that I've been doing for a long time, and I have also nice cases with pink composite, but it was always a huge challenge to achieve a nice aesthetics with pink ceramics. With pink composite, it's much easier and much more predictable. So we see the restoration now. The crowns are finished and glazed, polished, and the pink is also finished. So these now are the main advantages that I see to use composite on cases like this, on the gingiva aspect. First, preserving the physical properties of the PFM restoration. So I'm saving at least 2 or 3 bakes here that I'm not having to do because I'm not doing the pink and ceramics. And we know that every time we bake a bridge, we are removing some of the optical aesthetic aspects of the ceramics. So the less we bake ceramics, the better for aesthetics. So I'm getting nicer crowns by doing pink in composite. Also controlling, as I mentioned, the aesthetics of the pink. So shape, shaded, texture, much easier, much more predictable. That means many more people can actually do this kind of restoration, make this kind of restoration to look good. Repair and maintenance, that's another aspect that, so the pink composite combined with screw retain restoration really gives me a safe, what I would say a safe restoration. At any time we can unscrew this bridge. If the patient comes back in 1 year, 5 years, it doesn't matter, we can unscrew, we can repair, we can fix the composite, we can add, we can trim, we can repolish, we can even redo the pink composite completely without interfering with the ceramic crowns, saving the ceramic crowns. So it's a dynamic restoration. And if the patient comes back and his natural tissue changed the position a little bit, we can, utilizing the same restoration, add some more composite and remodel the interface and make it look good again. So everything with this technique becomes more predictable and safer. The downside, we would say, the composite doesn't have the same properties as ceramics. It doesn't last that long. And actually, this, I don't think that even is a downside, because the combination, as I said, of the pink composite with the screw retain restoration gives me the possibility to have a dynamic restoration. So actually the fact that we can change this shape and the shape of the artificial gingiva gives me a very comfortable situation. So that's not actually, even though the composite doesn't last as long as the ceramics, we will always be maintaining this restoration long term. So we see here now the restoration in place. So we have the interface on the apical side that it's not very aesthetic demanding because it's hidden behind the upper lip. So really what we want to blend in very well are the lateral interfaces on the distal of both laterals. Make them blend in nicely with the cuspid and with the artificial, the natural gingiva of the patient. And of course, how to clean and how to maintain, that's key for this kind of restoration. That's why we really have to plan ahead for pink and place the implants on the correct position and design the restoration correctly. And that's why the temporary, the provisional is so important, to test the design of the pink and the cleansability and the interface with the natural gum. So we see here, we go through step by step with the patient, even with the hygienist in the office. They have to know how to teach, and it's not really a big deal. The patients have been using this for a couple years, and they can maintain this very, very well. So we see here on the distal of the laterals, on both sides, we're just gonna, with a regular floss, we're gonna go around one lateral here, go around this pink wing that I call, and underneath the restoration with the floss, and then on the same thing on the other side. Go around the lateral, underneath the pink, and then fold around the implant. And then because we have 3 implants in this case, we're going to use a threader in 2 spots in between the implants. So we can actually even design some little grooves on the artificial gingiva to guide those threaders to go right in the position in between the implants. We see here the patient using the threader, and then after passing the floss, folding to one side and then folding to the other side. And the same thing in between the other 2 implants, the threader, and then folding around the 2 implants to the right and to the left. So cleaning, it's very easy, no problem, and the patient can maintain these restorations without any problem. If something comes up, the patient comes back without being able to clean something, we always tell them to make sure that if something is not right, to come back to us, and of course we can unscrew the restoration, reshape underneath, and remodel the artificial gingiva to give the possibility to clean correctly in a way that we are not taking out the aesthetics of the restoration. So we see here the integration with the lips, and that's very important for us, made us very happy to be able to reestablish tooth morphology. And tooth morphology depends completely on the support of the artificial gingiva, on the support of the gingiva. So gingival margin and papillas on the correct position will give me the opportunity to design nice tooth morphology. And we see here, analyzing on the side view, if we compare the natural papilla here with the artificial papillas here, it blends in very nicely. On the same thing on the other side, how the amount of tissue that she's showing on the natural papilla is very similar to the amount of tissue that she's showing on the artificial gingiva. And that's really, like I mentioned, only possible with teamwork. So restorative team, lab team, surgical team, all together planning from inception, planning ahead for these procedures. And we see here the final situation of the patient with her smile, and we were really happy to be able to give her back a situation here very similar to her situation before the accident. And it's nice to see that the amount of papilla that she was showing here when she was smiling, very similar to the amount of papilla that she was showing here on this side, utilizing a technique that made it possible without any further surgical procedures. So we really saved time and saved even money, because it's very expensive, all those surgical procedures, and the patient was able in a couple of appointments to place the restoration and reestablish the soft tissue that was missing. And we also here we just wrote an article, three-part article about this specific subject with the whole philosophy and the whole concept that is going to come out end of this year, beginning of next year, 2009. And we also give a hands-on course on these subject with practical and clinical considerations about all these procedures and how do we plan and how do we do these cases. And all this information, of course, is in Dental XP. You can get more information about the article or about the hands-on course on this subject. I always, of course, like to thank my team on the lab, Team Atlanta Lab. Everything that was shown here, they had a big participation in everything that I do. So it's always very important to have these guys around. And always, thank you also, and I hope it was helpful, and I hope everybody enjoyed. Thank you.